Thank you, ma'am. Ma'am, kindly introduce our eminent speaker, Dr. Deepti Jami, ma'am.
Yeah, sure. Can you project the slide, please? Yeah, good afternoon, everyone. I'm very happy to be a part of the CME. I'm very happy to introduce Dr. Deepti Jami, who is after his MS OPG graduation, she has done a postdoctoral fellowship in fetal medicine from Tamil Nadu MJ University. And she has got a fellowship in advanced OPG gyne ultrasound from Mediscan. And she's a director and fetal medicine consultant in Chennai Women's Clinic and Scan Center, and fetal medicine consultant in Apollo Cradle, as well as Anuradha Maternity Center. She has bagged the best oral presentation in Delhi in 2015. And she was also a gold medalist for a best oral presentation and gold medalist in the forensic medicine, ENT, and pediatrics during her undergraduation. And she was the best outgoing student and intern in 2016. And she was a winner of the lab in Indian Academy of Pediatrics quiz in 2006. I request and invite Dr. Deepti Jami to take over the session.
Thank you so much, ma'am. At the outset, thank you so much, Saveetha ma'am and the entire team at Saveetha, and presenting in front of Anjalakshmi ma'am on a GDM topic itself is very special to us. Thank you so much for having me over. Ma'am, can I share my screen now? Yeah, can you see my screen now?
No. Yes.
Yes,
ma'am. Go to the slideshow, ma'am.
Yes, ma'am.
Go to slideshow.
So I think today the entire hour, 1 hour of what we are going to discuss is hyperglycemia. And for me, the scope is just for 5 minutes. So when I saw the 5-minute schedule, I wanted to wrap up as much as possible, both the practical points and how to combine theoretical knowledge into practical. So what we are going to see in concise position in next 5 minutes are these 5 things. Why do we need glycemic control? What is the incidence, as Anjalakshmi ma'am had already pointed out? What are the fetal defects we need to look out when we are scanning a mother, let her be a pre-gestational diabetic or a GDM mother? A possible pathogenesis which has been put forth for the occurrence of fetal defects in a hyperglycemic mother. HbA1c correlation, which is extremely important, not only for scanning during an anomaly scan, but also for counseling in early, because we get plenty of patients with HbA1c above 9, 10 during the first 3 months asking us whether we can continue the pregnancy or not. And last but not the least, prevention. So I know I can understand that there are plenty of postgraduates and undergraduate students. So for them to know, yes, as ma'am rightly pointed out, the incidence, which was around 3 to 9% initially, the abnormal glycemic control has shifted towards 10 to 15% of pregnancies nowadays. When we see almost even in scan, when we see out of say 10 patients, we see minimum 2 or 3 are becoming either GDM or a pre-gestational diabetic nowadays. So it's very, very important that we know how to handle these patients right from the fetal medicine perspective as well. So the malformation, yes, there's around 5 to 6% of malformation, and the malformations correlate with the control, glycemic control. Let it be type 1 or even a type 2 diabetic medicine. So perinatal mortality and maternal mortality has significantly reduced from as high as 50% to 9% now. And even fetal and neonatal mortality rate has come down from 65 to 20 for every 1,000 live births. But the point here to note is congenital malformations still remain high, because most of these patients, that too specifically pre-gestational diabetic patients, either the pregnancies are unplanned or their glycemic control is not under perfect control. So what are the proposed theories? Because all of us know, this is the basic knowledge, all of us understand that during the first trimester, during the organogenesis phase, what happens when your glycemic control is not that good? You will get into a diabetic embryopathy or hyperglycemic embryo. What happens when it is during the second or third trimester? Obviously, it's going to be shifted more into macrosomia and all metabolic derangements in the neonate. So that for my next speaker is going to deal with. So right now we need to know hyperglycemia and congenital malformations. What do we need to see in scan from the scan perspective, and also how to counsel those couple? So the pathophysiology, when we know that pregnancy itself is a diabetogenic phase, there's some amount of insulin resistance which happens. So obviously when there is hyperglycemia, there isn't enough insulin resistance happening there. So what happens, there is an increased glucose rate. So when this amount of glucose increases, obviously it gets transferred into the embryo through the placenta. And what have been the pathogenesis? If you see here, either let it be a pregestational diabetes, or that's type 1 or even type 2, when there is hyperglycemia which is happening as early as in the first trimester or even the second trimester, there are three pathways you need to look at it. One, the first pathway is oxidative stress. When it releases oxidative stress, it stimulates the cascade of stress signaling, and this by in turn dysregulates all the gene expression. So what happens, there's excessive apoptosis, and the main two target organs, one more point which we need to remember is two main target organs are the heart, the embryonic heart, and the neural tube. So these two organ systems are extremely crucial when a mother is hyperglycemic. And what else happens? Transcriptional changes and also epigenetic factors which can play a role in culminating into a diabetic embryopathy or a fetal embryopathy. So these are the proposed theories when a mother is hyperglycemic. So then what are the range of abnormalities? As I already told you, both CNS and fetal heart. What happens in the developing embryo, because the cephalic neural crest cells and the mesoderm gets affected when there is hyperglycemia, and there is increased incidence or increased release of glucose-free radicals along with apoptosis. So as I told you, there's varied range of defects which you can actually identify. The commonest being the cardiac anomalies, where you could have an ASD, VSD, or an outflow tract abnormality, as you can see over here. Truncus abnormality in CNS, what you could identify is an as clear as an acrania or an anencephaly or a neural tube defect. In gastrointestinal system, you could either have a duodenal atresia or a hydronephrosis. And more so, when you combine CNS neural tube defects, you cannot miss the spine. Musculoskeletal system, you could have a caudal regression syndrome, sacral agenesis. In very, very rare abnormality, we do see cyanomelia as well. So all these systems are involved. And the most common, as I told you, there's threefold increased risk in the cardiac abnormality. And what is the most commonest cardiac abnormality which we would find in a hyperglycemic mother for a fetus is VSD and TGA, when compared significantly higher when compared to the non-diabetic group. So apart from that, it's extremely important. We see the heart nowadays. We've been screening the fetal heart as early as in the first trimester. And in my last few slides, we're going to see how we can predict in the first trimester as well. Apart from these cardiac findings, 70% will have PDA or neonatal period, a patent foramen ovale, or a small VSD, and few patients with cardiomyopathy as well. So maternal interim is a significant risk factor for congenital cardiac defect. Apart from that, as I already mentioned, no doubt neural tube defects, anencephaly, caudal regression syndrome, and spina bifida or neural tube defects. So it's extremely important that we see these two main structures when we know our antenna should be up, when we know that the mother, let her be a type 1 or a type 2 diabetic, we need to make sure that her glycemic control is there. If not, if her HbA1c is high, these two main systems at any point of time, first trimester or early target scan as early as 16 to 18 weeks, or even during the anomaly scan time, we have to have a watch. A fetal echo is a must to identify these abnormalities. As I explained earlier, yes, there are other abnormalities as well. When we compare to CVS and CNS, hydronephrosis, duodenal atresia, small bowel obstruction, or even cleft lip and palate or single umbilical artery. So why and what is the importance of HbA1c? As I told you, we have come to the part where we need to have a look out. And how do we stratify? Obviously, when a couple come to you, we had recently 3 or 4 couple within a short 2 to 3 weeks span of time with HbA1c 9, 10, 8.9. Because when you see here the graph, when the HbA1c is less than 7.9, when you can see the risk maternal malformation, that's a major fetal malformation ratio, is around within 5%, but it exponentially increases when the HbA1c level goes beyond 9. So this point is very, very crucial, because from 8 to 23% higher when it goes beyond 10%. So because when we have a cutoff of 9 or 10, we need to sit down and talk. Out of those 3 or 4 patients, 3 of them are actually continuing the pregnancy, even though we have counseled them, we have seen them in early target scan. We've reassured that as of now, the structural normalcy is there. One patient opted because her HbA1c was 10.5. So this is within just a month, 3-4 weeks. But then we can actually see the HbA1c plays a major role in counseling the couple, that too in early trimester. And if the HbA1c is beyond 9 or 10, it's very important for us to explain them the chances of either evolving anomalies, the postnatal anomalies, or even occult anomalies, which might not be even picked up in an antenatal ultrasound. So yes, more to reiterate, the almost a close recent review on Jan 2019 review, it's very clear that there is definite role of HbA1c when put across along with congenital anomaly, that the rise in HbA1c exponentially will definitely increase the major congenital anomalies in the fetus. No doubt about it at all. So I told you I'll give you a clue. This one study, they have actually seen the pre-gestational diabetics. Out of these 154 patients, 11 of them had anomalies, 7 were cardiac and 4 were extracardiac. And out of those, 6 were being able to identify prenatally. And when the HbA1c is above 7 or 8 itself, definitely you have to have a lookout for abnormalities. However, they found that abnormal NT did not predict anomalies, but what could happen is tricuspid or ductus venosus as early as in the first 3 months, because ductus venosus, A-wave reversal changes is a precursor for a cardiac anomaly. So we need to make sure, even in a hyperglycemic mother, not under much control, we do look at the ductus, not just the NT alone. The cardiac screening is a must. It is within the protocol nowadays during our first trimester screening, at least the color flow into the forechamber and the arches. We need to document a definite picture of that, because it gives a lot of reassurance that major abnormalities, at least we're able to rule out in cardiac say. So ductus venosus A-wave reversal in a hyperglycemic mother, definitely call them back at 16 to 18 weeks for an early target and an early fetal echo. So what I want to conclude is that yes, pre-gestational diabetes is definitely a rising problem, no doubt. Remember 2 systems, apart from the rest of the systems which will get involved, CNS and cardiovascular. The pathogenesis which has been put forward now, even though it's not very clear, the first pathogenesis is oxidative stress, and the stress kinase signaling induced increased apoptosis, leading on to diabetic embryopathy in the fetus. Most of the defects we see when the pregnancy is either unplanned, or they have not been under proper control, or they have not been following the treatment methodology what the diabetologist has given them. Pre-conception, the ideal time to catch all these couple is during the preconceptional period. And yes, HbA1c higher than 8 is definitely, we need to make sure that we counsel the couple accordingly. And how will we stratify them? Like how we stratify many other conditions, as in twins or anyone, we stratify them saying, first, you need to see whether it's a pre-gestational diabetes about the HbA1c. The second bucket comes when there's high BMI, but they develop GDM, that's during pregnancy. And the third bucket, when these mothers, GDM mothers without any pre-diabetic risk factors like high BMI or family history. So this is the cutoff bucket. So you need to be very careful with the pre-gestational diabetic mother, high BMI, whom you know who might get into GDM, or GDM mothers who actually don't have much risk factors when they started their pregnancy. GDM is not without its own risk. The next speaker is going to talk about macrosomia and other ultrasound factors which can be predicted, ultrasound markers which can be used to predict a GDM baby or a macrosomic baby. So GDM, when the mother is gestational diabetic, you need to look out for macrosomic signs and also postnatal glucose metabolic derangement. Once again, I would like to thank the entire team at Saveetha for giving me this wonderful opportunity. Thank you, ma'am.
Thank you, Dr. Deepthi. That's a wonderful presentation in just 5 minutes. Really wonderful. And as of now, there is no questions in the question box. Dr. Archana, shall we move on to the next session?
Yes, ma'am. Yes, ma'am. Kindly introduce Dr. Sudarshan sir.
Yeah.
Ma'am.
I'm very happy to introduce Dr. Sudarshan Suresh, who has completed his MBBS from PSG Coimbatore and has done a DNB in OG and from Southern Railways Headquarters Hospital, Chennai. He has done a fellowship in fetal medicine from Mediscan Systems, Tamil Nadu MJ University, and is a consultant of the fetal medicine Mediscan Systems, Chennai. And he has Can you put on the slide, please, Archana? Okay, he has got an extensive experience in fetal diagnostic and therapeutic procedures, and many procedures like amniocentesis, CVS, fetal reduction, radiofrequency ablation, and fetoscopy, laser, etc. He has developing organizing protocols for specialist units in fetal medicine, setting up the protocols for a first trimester unit and multiple pregnancy clinic, an invasive procedure unit, and all this been in the Mediscan from 2015. And he has been the joint organizing secretary of CUSP and biannual national conference in ultrasound and fetal medicine. He is guiding many students in paper publication. Over to you, sir, Dr. Sudarshan, sir. Dr. Archana, Dr. Sudarshan is not getting connected.
Sir, Mr. Balaji, sir.
He was there before.
No, Dr. Sudarshan is there, his mic is off.
Unmute.
Dr. Sudarshan, can you please unmute yourself? Dr. Archana, can you call him, please?
Okay, ma'am, I'll call
I
him.
just called him, he's coming.
Oh, okay, thank you.
Can you hear me now, madam?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
Thank you, madam. Sorry for the connectivity issues, madam. I'm just joining. Okay. Can I just share my screen?
You can, sir.
1 second. Okay. Can you see my screen, ma'am?
Yes, sir.
Thank you. Okay. Right. Very good afternoon. And this session I'll be dealing with on the ultrasound prediction of macrosomia on whether this is actually feasible or not. So I'll just take you through a couple of cases to show you how things work when we do the scan. This was a second gravida diagnosed as GDM at 32 weeks, and fasting sugars were 130 and postprandial were 150. And these are growth curves. You look at the growth curves at the 28-week scan, the growth of the baby is somewhere around the 70th or the 80th centile. And when she has reached around 32 plus weeks, you can see that there is an exponential growth in the abdominal circumference percentile, where it has crossed over 95th percentile. And you can also see the EFW touching 95th percentile. So these are the baby. So this baby also, you could note this thickness in the abdominal wall. This is the abdominal circumference that is taken. Normally you see the abdominal wall as a thin line. Here you can see an echogenic thick line that represents a subcutaneous tissue. Similarly, an assessment of the limbs of the baby at this stage showed a very significant amount of subcutaneous tissue noted. So at 34 weeks, at 34 weeks, this baby had an estimated fetal weight of around 3 kg with a significantly increased subcutaneous fat that made a diagnosis of significant macrosomia. This was case 2, and this lady was pre-gestational diabetic, and she was on a very large dose of insulin and HbA1c of close to 7, strong family history of diabetes, and again, case with macrosomia, as you can note here, as seen by both the growth velocity and the EFW. The things that we're going to note here are again the exponential growth in the abdominal circumference and the fetal weight, and the EFW percentile, which is around 98 percentile. So at 28 weeks, we expect a baby to be around 1 to 1.2 kilos, while this baby had a weight of close to 1.95 kilos. A very similar ultrasound picture of a prominent subcutaneous fat noted, but you can also see this is the nostrils, and these are prominent cheek pad fat that you can see here, seen by both the B mode ultrasound and by the 3-dimensional rendering image. So the common factors that we have noted in both these cases are A, both the patients are diabetic. I specifically put up these cases in conjunction with the theme of the meeting. 2, the EFW, or the estimated fetal weight, which is computed based on the biometric parameters, was above the 90th percentile. 3, the growth velocity is more. And 4, very, very prominent subcutaneous fat is seen across the different portions of assessment of the baby. So does things, or are things so easy, and and how good are these parameters, and how accurate can we diagnose macrosomia on ultrasound? Because if we see a picture completely like this, a diabetic pregnancy with all these features of both the weight, the velocity, and the fat, then your reporting of the baby having a macrosomia is much more easier. But you don't see this combined picture all the time, but still you have pregnancies which get into trouble after birth. So macrosomia is basically defined as absolute birth weight of more than 4 kg, or a severe macrosomia where the complications are more, where the birth weight is more than 4.5 kg, or a birth weight greater than 90th percentile for the gestational age. Our whole goal in assessment of this is because we want to know how the fetal and the neonatal outcomes will be. And there are difficulties in this. The difficulties in this is because of the fact that these growth curves in these diabetic pregnancies, or this growth parameter change in diabetic pregnancies, are not exactly sacrosanct across different ethnicities. These studies which reported on diabetic pregnancies and growth parameters and the relationship of ethnicity showed that though the South Asian babies are a little smaller, the adiposity appears to be different, and this varies with the severity of the diabetes. And this is very, very worrisome, because our ultimate goal at the end of the day is not only to predict whether the baby is growing large, because as I'll show from data, it's not the largeness of the baby does not translate directly into an adverse outcome, but also to predict if there could be some parameters with which we can identify babies which are at a higher risk for long-term metabolic concerns, so that we can try to modify these features in utero, or identify a subset of pregnancies where the body fat percentage is little more, and even though they are not very significantly macrosomic, they are at a higher chance of having neonatal complications like shoulder dystocia. So if we look at these subgroup of pregnancies, as I said, we are worried about the short-term problems, adverse outcomes during the perinatal period, and also the long-term concerns. So this large systematic review discussed about the maternal and neonatal complications of macrosomia, which we need to have in mind, because this would serve as a base to what we're going to discuss in the next few slides. And this large meta-analysis, published recently a couple of years ago, showed that the risk of section, postpartum hemorrhage, obstetric anal sphincter injury are around 3-fold more in babies who are weight of 4 to 4.5 kg. But the concerns are the fact that the risk of shoulder dystocia is around 9 times the odds and 15 times the odds. But what this paper again gave us information was, though macrosomic babies are more prevalent to have these complications, more than half of the pregnancies with shoulder dystocia actually occurred in infants that weighed less than 4 kilograms, which means these babies which were less than 4 kilograms had a very disproportionate development of the subcutaneous fat tissue in the subscapular plane, which made it difficult for these babies to during the time of the delivery. So the actual birth weight of the baby is actually also not very predictive of the outcome. The majority of the cases of adverse outcome due to a macrosomia actually happens in a normal birth weight infant. So this Cochrane review, which was published a few years earlier, again looked at whether if we identify the macrosomic infant and then did an elective induction of labor prior to 40 weeks, whether it will reduce the risk of shoulder dystocia. What this Cochrane review said was, yes, it would reduce the rates of shoulder dystocia, but it may not reduce the risk of the greater complication, that is the obstetric brachial plexus injury and intracranial hemorrhage. So with this background, what we have understood is that diabetic pregnancies are more prone to macrosomia, but that macrosomia does not directly correlate to neonatal adverse outcomes, because a significant number of pregnancies with neonatal adverse outcomes happen in babies which are less than 4 kilo. With that difficulty that we are facing even in the neonatal period, how well can ultrasound perform? If you look at the history of ultrasound to assess the fetal weight, the history goes back to as early as 1975. So it's been a really long time, more than 4 decades have passed. And after 4 decades, if we are still discussing about a modality on how good it is, it means simply that we have still not reached the point where we are extremely successful. If you look at the parameters that we use the abdominal circumference. The abdominal circumference was initially reported as having the best and the most efficient method to identify macrosomia. And when the centiles are more than 90%, then over 78% of the babies would have macrosomia. Then the second parameter which came up was the growth velocity curves, which we saw in the other 2 cases, for which if we plot them in the growth curves, this would tell us a fair degree of how good or bad the glycemic control was, resulting in an exponential growth. However, the recent papers which again spoke about growth trajectories in South Asian mothers, if you look at this paper, these are charts which talk about the abdominal circumference and the weight in pregnancies with moderate to severe diabetes. If you look at that, at 32 weeks, the abdominal circumference was at this plane, while at 36, 37 weeks, there has been a significant rise in the abdominal circumference and the weight percentage in these pregnancies with moderate to severe diabetes. So to see if if we could have a parameter better than the AC, the estimated fetal weight, which was calculated using multiple parameters, was used. But with respect to estimated fetal weight, there are very, very significant challenges in measurement, especially in late 3rd trimester, say at 37 to 38 weeks. At that point of time, even a small change in the caliper placement can result in an EFW variation of close to even 500 grams. So a caliper placement resulted in an AC of 310 versus an AC of 322 resulted in an EFW of 2.3 kg versus a 2.8 kg. So 1 centimeter error in placing the caliper in abdominal circumference can translate to a very significant variation. And in late 3rd trimester, with the baby in a difficult position, getting a perfect abdominal circumference to get the weight is difficult. That in essence explains the challenges that we see. And after so many years of calculation of various formulas, what was ultimately shown was that the Hadlock formula, which was reported first in 1985, still seems to be the best formula for calculation of the weight. And the 4th parameter using for diagnosis of macrosomia is a subjective and the objective estimation of fat. I showed you subjective estimation of fat. If you're able to see these skin folds in the limbs and this fat pad in the cheeks and the face, then it does translate to babies having a higher risk. But a more objective method are measurement of the abdominal wall thickness using automated tools. This was a publication which came out of our unit a few years ago on assessment of fetal adiposity prior to the diagnosis of the gestational diabetes. And what we saw in that paper with these numbers was essentially that the abdominal wall thickness fat is more around 4 to 6 weeks ahead of the diagnosis of GDM. And this may help to predict and give a lead time to intervene so that we are able to lessen the chances of these baby going macrosomic. What it essentially tells us was your weight estimation in the mid trimester doesn't actually give you any clue, because whatever change in the growth happens in the late trimester. Probably some soft parameters like this may help you give a warning to have a subset of pregnancies which have a higher risk of development. And the last one is when we looked at the growth velocity, we saw that growth curves give us a visual representation of the change in the growth velocity of the pregnancies. But again, very recent evidence in 2020 and 2021, again has shown that when they compare the growth trajectory of the AC, growth trajectory of the estimated fetal weight, to the standard single dimensioning of the EFW by Hadlock formula, the sensitivity of both the AC growth trajectory and the EFW growth trajectory was hardly 20%, while the standalone measurement of the weight, a single parameter by the Hadlock formula, had the best sensitivity. So things are changing. What we thought was extremely good a few years ago has changing significantly with availability of recent evidence. Again, one more piece of evidence which showed that a longitudinal biometry did not improve the prediction of macrosomia over a single biometric value. And again, versus 28 to 36 weeks, the prediction of macrosomia is much better when performed later. So if I summarize all this, I can summarize it by two large meta-analyses which came, which described about the prediction of LGA by a third trimester ultrasound. Let's just take home the messages from these papers. One, the prediction of babies with birth weight of more than 97 centile or more than 4.5 kg baby, that group is better than the babies with a birth weight of more than 98 centile. Second, when you look at the ultrasound tool, an EFW of more than 98 centile helps give you a prediction of around 65%, while if you use a lesser cutoff, you can get a subgroup of babies with LGA much larger, but that is associated with the high false positive rate. So we stick to an EFW of 98 centile. We still see that the prediction of LGA is only around 65%. But what is more stark is this, is that when you use the same parameter of EFW 98 centile, but get the scan within 10 days of delivery, say if you have a scan at 37 to 38 weeks, then your prediction improves from 65% to close to 85%. So the key messages from this are: one, the predictive performance of ultrasound for an LGA neonate is higher if the scan is carried out later, say at 37 weeks. Two, the method of screening is a weight rather than the AC. Three, the outcome measure is a birth weight of 97 centile. And four, if delivery happens within 10 days of you doing the measurement. So again, as this newer meta-analysis gives you, it gives exactly the same information, and this has come out in 2021. Prediction of birth weight more than 4.5 kg is better, EFW is better, and again, Hadlock formula is better. So despite years of research and years of having publications after publications on prediction of macrosomia, the key messages that we get are, we are able to predict babies which are supposed to be much more heavier better, and we use the weight that is the best parameter, and still the 1985 Hadlock formula is the best. So I will conclude this talk by giving you this last bit of recent evidence that because all these formulas have all these difficulties, some recent evidence tried to use non-standard biometric parameters to compute if you could predict babies are macrosomic or predict the weight better. And these utilize the soft tissue masses and the abdominal wall thickness masses and the mid-thigh fat masses. And this publication, which came last year, helped to look at the ultrasound evaluation of the fetal fat tissue and the cord measurements in type 1 diabetic and gestational diabetic pregnancies, and whether if you incorporate this in a formula, you can make the weight estimation better. And what this paper actually said was, yes, over and above our standard Hadlock formula, if at this late third trimester, we include all these parameters also in a specific algorithm, then the prediction rate improves to close to 90%, and the error rate in your weight estimation is much lesser compared to the Hadlock formula. This does involve utilizing or doing much more number of measurements over and above our standard biometric parameters. But if it does improve our prediction, yes, this may be something which may become the norm a few years later, but not still now, because these formulae have still not been established in larger population, and doing it on a routine basis would again be challenging. See, if you have to go and do these measurements of the liver size, the subscapular skin thickness, abdominal wall fat thickness in all these babies may be difficult. But if we get a subgroup of babies which are growing above the 95th centile or above the 90th centile, and we add these parameters, and if we are able to give the prediction better, then that may be the way to go. So to conclude this talk, what I've put across is that to predict macrosomia, there is a very large number of evidence, but still there is a long way to go before we stumble upon the perfect formula to prevent complications with more definitiveness. We have certain standard things which have been established, but what we are seeing is that more and more evidence is coming upon which increases the prediction better. And of late, again, these AI technologies which are improving these automated measurements in the machine may become the way that we go in the future, especially to do these non-standard biometric measurements for us to predict macrosomia better. Thank you so much.
Thank you, sir. That's a wonderful presentation, because always we face the challenge of predicting LGA baby while giving the GDM. There is a question in the chat box, sir, for you. Can you highlight on the adiposity appearing 2 weeks earlier? Any normograms for the gestation age?
Okay, see, this abdominal wall thickness study was, there is no, we have the nomogram with us because this was a study done at our unit here, where we had the first part of a study where we did the abdominal wall thickness measurements and standardized the measurement using the automated tool. That is, we validated the automated tool measurement for the abdominal wall thickness. And the second part of the study was utilizing this automated tool to measure this and plot it in the nomograms that we had obtained by our pilot or the first part of the study. Yes, we have nomograms with which we use that. It is there part of the publication.
Okay, sir. Thank you so much, sir.
Thank you.
I think as of now, no other questions. And thank you so much for the wonderful presentation, sir. Dr. Archana, can we move on to the next session?
Yes, ma'am. Thank you, ma'am. Thank you so much, ma'am. Now moving to the next session, it is a case-based discussion. I would like to invite Dr. Shanti madam to introduce our moderator and our panelists, sir. So over to you, ma'am.
Archana?
Yes, ma'am.
Yeah. Shanti is there?
Yes, ma'am. Madam is there, but I think she is having some difficulty in connecting, ma'am. Okay, ma'am. I will introduce, ma'am.
No, I will introduce, madam. Ask them to project the slide.
Okay. Mr. Balaji, sir, please project the slide of Dr. Lakshmi, madam.
Yeah, one moment.
Yeah, it's my privilege to introduce Dr. Lakshmi, who is a very good friend of mine. And she's a very eminent fetal medicine specialist and a good gynecologist. Dr. Shanti is there? Okay. So she was here previously in Triple M. Now she is presently working in abroad, Formley Park Hospital. And she is a very good obstetrician, taking a decision. And she's a certified person in perinatal mental health also. She has got active role in conducting postgraduate teaching in fetal medicine, perinatal, multidisciplinary meeting, organizing several CMEs, short courses. She is a former treasurer of Indian South Zone RCOG Coordinating Committee 2017 to 2020. She has presented and co-authored 15 papers at state, national, and international conference, and she has got nearly 50 publications. And I thought she has come here for a short visit. I thought I should utilize her expertise and experience, and I feel our students and delegates are lucky to listen to her. Over to Dr. Lakshmi.
Madam, thank you so much for the very kind introduction. Am I audible?
Yes, you're audible.
I will share my, can we have the panelists CV, please?
You would like to introduce Dr. Lakshmi? Shall I introduce?
Lakshmi, how are you?
I'm very well, madam. Thank you so much.
When did you leave our place?
1 year ago, madam.
Oh, okay, right.
But I'm always here, madam. In spirit and heart, I'm in Chennai always.
Okay, right.
Yeah. We have
nice to see you, Lakshmi. I said a tough moderator. I have given you the adjective tough moderator, okay?
Madam, moderating GDM with Anjalakshi, madam, is a very big challenge. I hope this will be an interesting and good learning experience, and I'm looking forward to learning from you all as well, madam.
Okay.
Yeah. Can I have the Dr. Vanitha's CV? Mr. Balaji?
Ma'am, just a moment, ma'am.
Yeah, I welcome Dr. Vanitha. She's a professor and HOD of Kill Park Medical College. She is a fetal medicine person, fellowship in fetal medicine, and she is trained in microsurgical recanalization. Also, her field of interest in high-risk obstetrics. Can I have the next? Welcome, Dr. Vanitha.
Thank you, ma'am.
Dr. Malati, she is also a fetal medicine specialist based, and she is director of fetal medicine and fertility center in Trichy. She has got a lot of best paper prize in UFOXY, and she is presently the president of Trichy OB-GYN Society. She is a member of various academic body. I welcome you, Dr. Malati.
Thank you, madam.
Dr. Sumati. Dr. Santosh is our own faculty. He is a neonatologist in our hospital. She has received a Varadarajan Award for Best Outgoing Student in Surgery and Orthopedics. And finally, he has landed in neonatology. He's basically, I think his interest is in surgery, I think. And he has got a prize from Madras University Student Club Endowment Cash Award. And he has got a silver medal for the best performer in surgery and orthopedics. Ratnavelu Subramaniam gold medal for best outgoing student of the batch. Specialized in neonatal Institute of Child and Health in Chennai. And I welcome our own faculty, Dr. Santosh. Next slide. Dr. Sumati. I know her for so many years. She's a very brilliant student and as well as a good teacher. She has got a wide experience in teaching. She's a nodal officer for emergency obstetric care. She's a state master trainer in colposcope. Her area of interest is cancer screening and social obstetrics. Welcome you, Dr. Sumati. Over to Dr. Lakshmi for the one we're waiting to listen to your wonderful panel.
Madam, can I share the screen now?
Yes, ma'am, you can.
Is my screen visible?
Yes, ma'am.
Is it in slideshow now?
Yes, ma'am.
Yes. Welcome to this panel. And gestational diabetes is something that has changed so much over the years. But I think one thing that we have now recognized is it's not gestational diabetes that has changed, but it is our outlook and understanding that has improved. I would like to welcome all the panelists, and we will keep the answers very short and brief so that we can cover as much an area as possible. So I'm going to now, in this talk, look at screening, look at perinatal management, and look at the future implications. It's our pleasure as a panel together to thank Hepzibah Madam and the team at Saveetha Medical College for giving us this opportunity. It's a lifetime learning that we have committed ourselves to, and it's indeed an honor to present in front of our own teachers, and we look forward to this being a good learning experience. We will start with screening and diagnostic tests. I think a lot of our job has been made easy by the previous presenters who have clearly outlined certain aspects. So we will skip them if that can help for time. The first case scenario is a 37-year-old with a BMI of 24. She's an Indian origin lady. She's had 2 previous pregnancies. The first baby was born at 3.3 kilogram at 36 weeks, whereas the second baby was 3.9 kilogram at 37 weeks. In both these pregnancies, she's had GDM, but she says she only required diet for management. So she was on medical nutritional therapy. The last childbirth was 2 years ago. There is obesity and diabetes, both in her mother and her elder brother. So the first question that I would like to pose to is to Professor Rajalakshmi. And this is to ask, when do we screen? Because already Madam has alluded that we should screen early. What is the practice, Madam, where you are working right now? Because there's a large volume that you handle.
Good afternoon, ma'am. I'm Dr. Rajalakshmi. Usually, we, as per recent guidelines, we used to screen at first antenatal visit and around 24 to 28 weeks with 75 gram OGCT, ma'am.
Okay, so this is what is recommended by the international bodies. Anjalakshmi Madam also mentioned about 3rd trimester screening. Which are the situations in which you would do that?
So for high-risk pregnancies like BMI more than 30, family history of gestational diabetes, previous history of gestational diabetes, we'll be doing around 30. We'll be repeating the screening at 24 to 28 weeks and also at 34 to 36 weeks now.
So you're just mentioning that whenever you have a higher index of suspicion, you would prefer to have further screening as well, so that you're absolutely sure. Isn't that right?
Yes, ma'am.
Yeah. So we will skip this question because we have already discussed that universal screening is the best way forward. And we will move into the next case scenario, which is a BMI of 40. Okay, and we are all seeing increasingly women who are large, and it is very important practice that we document weight and document their BMI so that we can assess their risk in a more systematic manner. This is a BMI 40 who is 28 years of age. She has had 1 previous pregnancy when she had a 4.3 kilogram baby at 38 weeks. But in that pregnancy, there was no GDM, and the test was done at 32 weeks. She had a last childbirth 7 months ago. There is a history of polycystic ovaries. What will be the ideal test to screen for her? Over to Sumati, Madam.
Yes, madam. Ideal GDM screening will be oral glucose challenge test, OGCT with 75 grams, which can be done non-fasting, even in a non-fasting state, which is said. So we have other guidelines from others, from WHO, NICE, and other things. What we follow in our setup in Government Institute, or NHM advises is the DIPSI guidelines, where we have 75 grams oral glucose test done. After 2 hours, we take the blood and find out if it is more than 140, we just tell them whether they are GDM, or if it is more than 200, in that test we tell it is diabetes. or if it is less than 40, we call them it is normal. So that's how we go about doing this test, and we done as early as possible in the pregnancy, because we had the previous history, the baby having a large forehead and other things. We have to do it as early as possible at the first visit itself. But only problem is the baby patient can have a vomiting in the early weeks. So that is to be taken care of. Otherwise, the timing which we usually advise is around 12 to 14 weeks, where the vomiting and other things subsides. That's the time we just go about doing it.
Sumati madam, going back in time before the GCT as such started, what were the other tests that you thought worked out well? And are you feeling now more comfortable with the new DIPSI recommendation to do a non-fasting 75 grams? Is it helping for managing a huge caseload in a more effective manner?
Yeah, the things which we were following when we were doing that, we had a two-step test, having a fasting, or first doing a O'Sullivan's test, and then after that, if they are positive with that, then we go in for a definitive oral glucose challenge test. It's a two-step test. This is more the diagnostic, and it's a more of a diagnostic test. Instead of having it as a screening test, this has got an advantage of being it as a diagnostic test as well. And those days we used to have a selective screening with taking the history and finding out the risk factors. Now we just go in for an universal screening with everyone. So that we find this has been very comfortable, and compliance is more and more number of cases are being diagnosed nowadays with the GDM, with this present guidelines and going about with screening, because it's very comfortable for the patients, because it is asked to come in the non-fasting state, which is very comfortable. So I think this is much better that we are able to find out or pick up more number of cases.
Madam, just one more thing that I would like to share is now I've returned back to UK for the last 1 year. And there what we are doing, and obviously there are resource implications for this practice, is those with previous GDM. We actually, if they have their own glucometers, we advise them to start doing glucometer screening itself periodically, and then do their 24-week test as well in addition, on and off. So that is something that requires a lot of resource implications, and I think that's something we cannot generalize. Can I ask Professor Rajalakshmi about bariatric surgery? Only because, you know, though we are seeing obese patients, we are also now beginning to see those that have had bariatric surgery. And there was something that I read recently about bariatric surgery and glucose screening. So I just wanted to see what was your view on this, madam.
So in those patients, those who have undergone post-bariatric surgery, we recommend FBS and PPBS, home glucose monitoring for about 1 week, ma'am. Because 75-gram OGCT, if we give to such patients, they may develop dumping syndrome, which is characterized by abdominal cramping, bloating, nausea, and vomiting. So we recommend regular CBG monitoring from 14 to 16 weeks onwards.
Madam, on the same ground, you mentioned these are the women who may not tolerate that sugar load, but a fair amount of women who actually take the 75-gram glucose also vomit, isn't it, madam? And many times the lab will come and tell us saying, we have given glucose, but this patient has vomited. What do we do? What is it that you usually recommend to these women in this situation and the lab?
So if there is vomiting, within half an hour, we can repeat the test. If more than half an hour, we can we have to repeat the test again, ma'am. We can continue with the same, or we have to repeat the test again, ma'am.
So when it comes to interpretation of the 75-gram load, it is important that the patient has tolerated it, and only then we can do the blood test. If the patient has not tolerated, then the test may need to be deferred. Would you agree with that, Professor Rajalakshmi?
Yes, ma'am.
Yeah. Professor Sumati, is that a common problem that you face in a busy center like yours, where people are not able to tolerate
yes, yes, madam. Yes, madam. But only thing what we say is the screening test which we are asking to do in the first trimester or as early as possible, we make it around 12 to 14 weeks mandatory for a large number of crowds. So when we generalize the term around 12 to 14 weeks, we don't see such things after 12 to 14 weeks. But if it has been asked to do it in the early trimester or early weeks, like 7 to 8 weeks or so, then it is difficult. Not much of a patients having that, because the gestation time, which has been generalized for most of the people who are doing it in the primary health center, other remote centers, we give it around 12 to 14 weeks. So that time we don't have much of a problem. We also say that if they are vomiting, means then it has to have a repeat test if it is done within half an hour. So they have to have come again for another day. If it is after half an hour, then we just take the test as such and go over.
So then all of us agree that giving a glucose load is a very helpful way to come to a diagnosis. But ideally, as much as we want to do it early in pregnancy, if we can time around 12 weeks, maybe that will help us to overcome some of the tolerance issues that they can have with the 75-gram glucose. How do we interpret these tests? Professor Vanitha, over to you, because we have done the test. Already, Anjalakshmi Madam has given us an introduction and asked us to look at numbers and make sure we stick to certain numbers for diagnosis. Would you like to remind our audience about the numbers that we are looking when we come for interpretation?
What we follow is the DIPSI guideline single step test, 75-gram OGTT, non-fasting OGTT. So we take a 2-hour postprandial blood sugar. That cutoff is 140 milligram per deciliter. That's the simplest and most economical that we are very comfortable doing with, and patient compliance is extremely good. So we follow this guideline. And coming to the WHO has endorsed the DIAD-PSG guidelines. And so in that, as I put in the slideshow, the fasting is 92, 1 hour is 180, and 153 is the 2-hour postprandial. But NICE guidelines, again, it's the 75-gram OGTT. That consensus is almost universal nowadays, 75-gram OGTT. One is the fasting and the non-fasting. So NICE guidelines, any one value more than fasting more than 100 and postprandial more than 140 is taken as abnormal, and GDM is diagnosed.
Can we just have Professor Rajalakshmi once more? And your unit also follows the DIPSI recommendation, isn't it, madam?
Yes, ma'am.
Yeah. So we are having that the DIPSI with the single value of 140 is being a very useful way of arriving at a diagnosis. Smriti madam, can we just have your views on other tests? Because we had Dr. Deepti very eloquently telling us how the HbA1c makes so much of an impact on anomalies. Can we use this as a test to diagnose GDM, madam?
So I do not know much about this, whether it can be used as a diagnostic test. But I think when there is a person who is already a known diabetic, I do not know about GDM, already a known diabetic, then for them it is useful for in the pre-counseling, pre-pregnancy counseling, HbA1c helps. And also in the first trimester, if they are coming the values, if you do, just we can find out whether they are prone for anomalies, and then it will give a guidance on whether it can be continued or to counsel whether it can be done. To use it as a screening test, maybe if they are coming presenting first time in the second trimester, they are just coming in the second trimester for a visit, that time we can just know about the values. So for as a screening test, I don't have any idea about HbA1c to be needed. And glucometer capillary blood test, this can be used because it's easy, and self-monitoring and other things, because it is nowadays, now people are not reaching the healthcare facility. They want the healthcare to come to their house or use it. For them, it can be useful. So this is all the idea I have.
What about Professor Vanitha? Do you think any of these tests can be used as the diagnostic test, or DIPSI remains your first priority, madam? We are talking about coming to a diagnosis of GDM.
We don't do at all, madam, for measuring the blood sugar control.
For diagnosing gestational diabetes?
No, madam.
No. Okay. So really these tests are more useful once we have an established diagnosis, so that we can monitor the patients rather than when it comes to arriving at a diagnosis. There are also 24-hour ambulatory monitors that are available. These are quite often used for the complicated diabetics because these involve equipment, require the access to a database for interpreting them. So though these tests are available, these are all tests that we use once we have diagnosed gestational diabetes, rather than to come to a diagnosis of gestational diabetes. So I would like to summarize the first section where we looked at screening and put to the audience the entire list of risk factors that we used to look at initially when we were in an era of selective screening. So we looked at demographic data of obesity, age over 35, non-white ethnicity, the presence of medical conditions like polycystic ovaries, hypertension, metabolic syndrome, current use of steroids, also the past history with congenital anomalies wherein they were not screened for diabetes in that pregnancy, the presence of unexplained stillbirth, past large baby, past gestational diabetes, family history of diabetes, and importantly, in the current pregnancy, when there is a multiple pregnancy, there is persistent glycosuria, where there is significant gestational weight gain, or there's a large baby on polyhydramnios, these becomes the trigger when we think more of gestational diabetes. However, we have thankfully now moved to a universal screening everywhere, but it is important that we remember these are the risk factors where the women will be more at risk. Asian countries definitely bear the brunt of diabetes, and we know that the development of diabetes in an Indian lady is 11 times more than a Caucasian. And when we look at family history of diabetes, this study in Poland looked at a group of women who did not have any chronic conditions, and they recruited them in the first trimester. And what they identified was that if both the mother and the grandmother in the family had diabetes, then the odds ratio for developing gestational diabetes was 8 times higher. Whereas the same thing was a 4.7 odds ratio if it was mother having diabetes. And this is about diabetes for which insulin also was required for the pregnant lady. Whereas the odds ratio gradually came down for the other risk factors of father being affected had an odds ratio of 3.6, grandmother being affected had an odds ratio of 2.3. And if the mother alone was affected, then a gestational diabetes controlled on diet, the risk was 2. So we understand the risk is higher for those with a family. So taking a good family history is very, very important. And we should clearly ask, saying, tell me about your parents, tell me about your siblings, tell me about your grandparents, so that we get the extended family history clear. We will move to the next chapter, which is on antenatal management. Is there an echo to my voice?
Yes, ma'am.
How can we? Okay. This is the next case, which is BMI 45, the same lady, but now we are talking about her being of a higher BMI compared to the 40 at which we screened her. And we have identified that at 10 weeks, she has a blood test showing a 95 milligram fasting and a 155 milligram after 2 hours of 75 gram glucose. Professor Rajalakshmi, what would be your plan for her management? She's 10 weeks now, BMI is 45.
So first we have to counsel her regarding the complications of GDM, and I would like to put her on medical nutrition therapy. And after 2 weeks, we can repeat FBS and 2-hour PPBS. And if FBS is more than 95, so the target value during pregnancies, FBS should be less than 95, 1-hour PPBS less than 140, and 2-hour less than 120. If it's more, we can start her on insulin. So about metformin, it's ideal to start after 20 weeks of gestational age.
Madam, but a lot of metformin is given nowadays for those on ART cycle, even periconception, isn't it, madam? So are you keeping the weeks as the cutoff, or are you keeping the blood sugar as the cutoff when it comes to additional management?
Blood sugar, ma'am.
Blood sugar. Shall we just discuss a little bit about medical nutritional therapy? And I would like to, for the benefit of all the audience, especially the undergraduates and postgraduates, highlight that this is the main therapy. So we advise that it should be timely eating. They should avoid overnight long fasting, And very important part of the medical nutritional therapy is the brisk walking or physical activity that must be emphasized to all pregnant women. They should also have good hydration and at least 2 to 3 liters of water in a day. And when we advise about the carbohydrate load, it's very difficult for women who are used to eating rice with sambar, rasam, taira, and all vegetables to say eat a small amount of rice. So we have to be realistic in telling them exactly what to do. But 1 palm size of rice is what would be the ideal amount that they should be allowed. So they can increase the amount of vegetables they take and the protein that they take with it. I think that is the advice that will help. Also, when they are hungry, for them to take protein snacks rather than carbohydrate containing snacks. So anything containing lentils is much better. And also, we should give them at least 7 to 10 days time for all this to become fully effective. Also, a common problem we see when we look at blood sugar charts is that the morning samples tend to always hold a high value. So for these women, to give them a late night protein snack can sometimes help to reduce. And in the UK, we generally tend to tell them to take some meat and cheese, but that will not be culturally acceptable in our society. So things like peanuts, nuts are very good, or even vegetables can be taken as a snack late in the night to help avoid this very high blood sugar. This very high blood sugar happens when there's long fasting because there is the ketotic process setting in and the fatty acid breakdown that is beginning to start. We will move to the next case scenario, and this brings home the topic that Dr. Sudarshan so well discussed, which is a large baby. So let's look at the obstetric management in this particular scenario. We have a 27-year-old who is a preemie with no past history. At 34 weeks, she measures large when clinically examined, and hence scan is done, and the scan shows a fetal weight on the 97th centile, abdominal circumference to be on the 95th centile, and there is polyhydramnios. And she has had a glucose tolerance test 7 weeks ago, which was normal. We repeat a glucose tolerance test now, and this is the result. We have 114 as the fasting and 201 as the postprandial. So we are going to discuss the antenatal care for this lady who is now already in the late 3rd trimester. I'll start with Professor Vanitha. In this particular scenario, what would be your preference of management, madam? Madam, your mic is on mute.
I would like to start with an MNT, medical nutrition therapy, but it might fail in this case because the fasting as well as the postprandial both are high. Whenever the fasting is high, the MNT mostly fails. But anyway, one week at least MNT we have to try, and then go on to insulin therapy, which has a better control over oral hypoglycemic agents because already the baby is macrosomic. So MNT followed by insulin will be my preferred line of management.
Professor Sumati, would you agree with madam, or would you feel we should start pharmacological interventions?
I would like to start concurrently. I'd start a medical nutrition therapy and along with that insulin. Because the postprandial is also high around 200. So I will not wait for the MNT to go about, because already the baby is large for dates and polyhydramnios is there. I would not wait for, because she's already 34 weeks. So another 35 weeks, I will not, I will start with insulin also along with the MNT. That is also there. If you feel that the patient will go in for hypoglycemia with that, then I will allow for admission and then allow for a 6-point test, having a glycemic profile along with it, and along that, accordingly, I'll adjust the dosage of insulin. Along with the MNT, I will add insulin also, not wait for 1 more week and start a little bit later. I'll start it straight away.
So now we will leave it with Professor Rajalakshmi because we have 2 different views. Professor Sumati says she's a little bit worried, understandable, because she's getting nearer the due date and we don't want to be missing on an opportunity to effectively control. Whereas Professor Vanitha feels MNT will be enough. What do you think, Professor Rajalakshmi?
I agree with Sumati, madam.
So Now there is a 2:1 split here of wanting therapy rather than only medical nutritional therapy for management. And we already looked at the target values where we want a 1 hour to be less than 140 and a 2 hour to be less than 120. I think it's important we recognize that the 1 hour and the 2 hour values are different, because in the UK, we have now moved to doing all the tests as a 1 hour. Though we do the diagnostic test as a 75 gram GTT still in the UK, we do for management only a 1 hour postprandial as our subsequent 2. I also wanted to just point here that in the WING study, if you can see, this drives home the message that as soon as a patient becomes postpartum, we are going to the non-pregnant values for the diagnosis of diabetes immediately. So the pregnancy values are, as we discussed, and the target values. But once we go to the postprandial levels, postpartum levels, we are looking at a value of 200 and more to diagnose the diabetes in a postnatal state. We look at the obstetric care. Professor Sumati, you mentioned that we are going to give insulin, and I'm going to ask you to highlight the obstetric care for this patient. But while I do that, I would also like to share with you the outcome of what happened. Okay, we actually did only medical nutritional therapy initially, and only then moved on to insulin for this patient. I know that is something you are not very comfortable with. Now tell us, how would you do her obstetric care, madam?
So this patient where you have a glycemic profile, as I said, I would like to admit her and also have a monitoring of this patient by doing a weekly, at least do an NST and then a weekly monitoring of that with a non-stress test or with an ultrasound and Doppler is necessary. In the meantime, we will be monitoring her daily also. Patient telling about her subjective feeling, as well as, because I already said I would like to admit her for her. So I'll be monitoring in the hospital with the daily monitoring, and also looking for associated causes, like as it has been put up, like she's also prone for preeclampsia and other things. Whether she's developing that also has to be found out. Also for infections where the patients can also go in for urinary tract infection, vulvovaginitis because of the high sugar levels, that also have to be addressed. So these are the things which I'll be monitoring, and also the baby will antenatal fetal surveillance is given. Since she's there in the hospital, we will be monitoring her morning and evening with a fetal heart also, and NST being done bi-weekly at least with a fetal Doppler also.
Madam, she's now 34 weeks. If this is a patient who is very compliant, understands, and will come back periodically to an outpatient clinic, would you be comfortable to allow her to be an outpatient, or would you still prefer her to stay for a period of time, madam?
No. See, it's only for the control of sugar or for a 6-point test, I'd like her to admit it. And after that, if everything is normal, where I am able to get her sugars under control, where the amount of insulin which I want to have has been standardized, then I can send her home, not necessarily till term or till the expected date of delivery, not necessarily has to be there. Only for just the control of sugar. In the meantime, I'll be monitoring her and ask her to come every week. Usually around 36 weeks, we ask them to come around every week. So for her, it will also be the same. Once her sugars are under control with the glycemic control, with the adjustment of the dosage of insulin, and then I can send her home, not necessarily till our expected date.
So Sumati madam's main concern is that we should get good glycemic control, and there should be a adequate supervision during the time of initiation of new therapy, so that we are not overdoing or underdoing the treatment. Am I right?
Yes, ma'am. Yes, ma'am.
So with diabetes, the risks that we are seeing in GDM are cesarean risk is increased, preeclampsia risk is increased, and macrosomia risk is increased. And what Sumati madam alluded to in the beginning about giving insulin is very well illustrated in this study, where we see that when insulin is given, and as actually in the WING study, their treatment of choice was insulin. They did not have metformin as their treatment of choice. So a high proportion of women were on insulin, and they found that the presence of insulin also indicated that these women are going to be at a much higher risk for complications. Dr. Malati, I know a lot has been said about ultrasound. You have a vast experience, and for you, the catchment is wide because you get people traveling from long distances coming to see you.
Yes,
so I would like you to share some of the experience about what are the complexities that you have faced when it comes to growth surveillance with diabetes.
The first and foremost, madam, before we start the scan, we ask the patient whether it's a diabetic. And after doing a biometry, the abdominal, can you hear me?
There is a lot of disturbance.
Can you hear me? There's a lot of disturbance. No, ma'am, can you hear me now? No, ma'am, can you hear me now?
Yes, yes.
Mama. If the abdominal circumference or the estimated fetal weight is more than the 90th centile, we label her as a large for gestation age fetus along with the polyhydramnias. Apart from that, we look for other things to predict whether this fetus is likely to become a macrosomia baby. We need to understand there's a difference between a large for gestation age and macrosomia. Large for gestation is what happens before birth. Once a baby is born, then we label it as macrosomia. So estimated fetal weight, anything more than 4 kgs at ultrasound is suggestive of large for gestational age. So if we find a fetus like that, then as Dr. Sudarshan earlier said, we do the abdominal wall adiposity, we do the thickness of the femur, the thigh, and the pre-buccal thickness is measured. So all this is mentioned in the reports predicting that this baby is likely to be macrosomic and possibility of shoulder dystocia is high, so that it becomes easy for the conception to manage this patient. As you said, when you find a large for gestation,
Dr. Malati, can you just hold on for 1 minute? Can all of the speakers mute our mic? Maybe the echoing will be better?
Yes, there is some echo from the other. Yes. So once we find a large for gestation age, I think we should call her back every 2 weeks, because very often when we find that there's a strict glycemic control, the macrosomia settles down, the large for gestation will come back to the normal growth velocity. And now off late, we have found a lot of research papers on 3D volumetric assessment of the estimated fetal weight. All these while we were doing only the 2D, now we do the 3D volumetric analysis. The advantage of the 3D volumetric analysis is that the error, for example, when you have a large for gestation age, the error in the fetal weight is 10%. Suppose a baby is weighing 4 kilos, you may have a 4.1 kilo or 3.9 kilo baby when you actually deliver. Whereas in a 3D volumetric analysis, the error is only about 6%. So we have started doing that, but there's a lot of still limited data. The papers are still coming out. We are in the process of doing a multi-centric trial, comparing the 2D and the 3D volumetric analysis for a macrosomic and large fetuses. So these are the things which we have to keep in mind. And we need to understand that when you have a estimated fetal weight of 4 kilos, the sensitivity is very low, but the specificity is very high. That when you have a larger estimated fetal weight, the sensitivity improves, but the specificity is low. So that's the difference. So when you have a 4.5 kg baby, we are better in predicting large for gestation age. When you have a lesser, maybe 3.5 or 4 kilo babies, where actually the sensitivity is much lesser, the sensitivity will improve with increased estimated fetal weight. So these are the things which I wanted to highlight. Just because we have a 4 kilo does not mean the baby is going to weigh 4 kilos at birth. It can be 4.1 or it can be still 3.9. So when you have a 4.5 kilo babies, we are more accurate in estimating the gestational age. So, and very important is the biometry is very, very important. Unless you do a proper head circumference bipolar diameter AC in the proper plane and the femur length and the Hadlock 4 formula, it becomes very difficult for us to do this, because we've seen many cases where they've done by the Hadlock 1 and 2, the EFW is much different when compared to the Hadlock 4 formula. So we're very particular about the growth velocity charts.
I'm going to just interrupt Dr. Malati for a minute, because I have recently, only 2 years ago, been in a very embarrassing situation of looking after sisters who delivered within 2 weeks of each other.
Yeah.
The mother that was obese and I predicted as a large baby and did an elective cesarean was a 3.5 kilogram baby. Whereas the lady, the sister that I induced, because I thought it was a normal birth weight, had a wonderful vaginal delivery of a 4.3 kilogram baby. Okay. So this is a scenario that we definitely face on a regular basis, isn't it?
Yeah, definitely. Definitely. But the error with the proper biometric assessment, the error should not be more than 10%. So we usually, when we deliver fetal growth restricted fetuses or macrosomic fetus, we usually call the consultant and ask what is the weight. So we cross check, and over time we have improved in such a way that for almost our estimated fetal weights are perfect. If suppose I give a 4 kilo, it will be maybe 4.01 or something like that. It doesn't go beyond even the 10% error. We are trying to correct with that almost perfect biometric measurements.
So what Dr. Malati is alluding is the audit that we have to do of all our scan findings.
Yes.
So that we know in our unit what is the predictability, so that based on that we can then counsel our women. Am I right?
Yes, ma'am. Sure. That's right.
So we will move on to one more aspect, which is insulin. And I think already this has been covered, and Professor Sumati is very well discussed why she would prefer an immediate insulin for this particular patient. So I will just move on to say that we started with medical nutritional therapy. 2 weeks later, we had to have insulin. And by 37 weeks, this patient has now got a next growth scan, which says that the fetal weight is on the 90th centile. There is no further polyhydramnios, and she's now on insulin. So my question is about macrosomia and its management. So can we, I think I have asked Professor Sumati a lot of questions. So if it's okay, can I move this question to Dr. Rajlakshmi? Madam, can you just give us your views on how you would time this delivery and what would be the mode of delivery you would prefer for this patient who's a primary gravida?
So she's a primary gravida with 30 on insulin. We will actually we are supposed to induce her by around 37 to 38 plus 6 weeks. Since she's having macrosomic baby, sorry, I forgot the weight of the baby. So we can do a pelvic assessment, and if everything is okay, we can allow her for a normal induction of labor. If the baby is more than 4 kgs, it's better to plan elective cesarean section.
So your cutoff is 4 kilogram because of the diabetes. Is that correct? 4 kilogram at term because the mother has diabetes is the cutoff that you're keeping. Whereas,
no, ma'am, if the pelvis is inadequate for the baby, we can go for elective cesarean section. Or
so you're going with the clinical evaluation and the estimated fetal weight. This estimated fetal weight is 3.9 kilogram, madam.
I'll go with her pelvic assessment, ma'am.
So you will consider a vaginal delivery for this patient and look to see the feasibility clinically.
Yes, ma'am.
Okay. So with macrosomia, this was something that I wanted to share with the audience, wherein in a very large study, and this has already been discussed by Dr. Sudarshan, that not all macrosomic babies are diabetic babies. So in this large cohort from Bahrain, they were able to see that among the large for gestational age macrosomic babies, 22% were those with hyperglycemia and pregnancy, which means that more than 75% did not have diabetes. And in this particular group, they gave a shoulder dystocia risk of 1.3% for those between 4.5 to 5 kilogram, and a 4% shoulder dystocia risk for those above 5 kilogram. But you must understand that when it was large for date, in this study, the clinicians had a discretion of offering an elective cesarean as well. So this shoulder dystocia risk is calculated based on those who then went for a vaginal birth. But in their calculation, they felt that 331 cesareans have to be done to avoid one brachial plexus injury. So the conclusion that I would like to draw from my understanding of literature is that we should individualize situations when it comes to macrosomia. We should be careful in the labor to watch for their labor progress, because a slow labor progress, failure to descend in second stage, these are all very important indicators that must not be missed in a mother with diabetes. And especially as the crowning is happening, if it is very slow with the receding head, we are very likely going to be facing a shoulder dystocia, and we should be prepared with that. Can I get Professor Vanitha to give her comments, please, about macrosomia and her experiences with the delivery? Madam, I think your mic is on mute. Professor Vanitha? I think madam is not there. So I will move on to the next question. which is about intrapartum care. Can I get Professor Rajalakshmi to take this question about the induction method if you want to do vaginal delivery for a gestational diabetes? Your mic is on mute, madam.
Yes, ma'am. We can go for cerviprime induction. If the pelvis is adequate, we can go for cerviprime induction. And during labor, we are supposed to withhold the morning dose of insulin if she is on insulin, and she can be started on IV fluids. And CBG monitoring should be done every second hourly. And depending upon the CBG levels, we can add insulin if needed.
And the importance of maintaining intrapartum glycemic control is to help to minimize the neonatal complications of hypoglycemia and electrolyte imbalance, isn't it?
Yes, ma'am.
Yeah. So here we have got also the need to ensure, because you have a BMI of 45 for this patient, isn't it? 40 and 45. So we need to make sure that the anesthetist is involved with their care, because they have a higher risk for cesarean intrapartum as well.
Yes.
And what about CTG monitoring, Professor Rajalakshmi? What do you think is the role of CTG in monitoring for a mother with diabetes?
So anytime she may go in for obstructed labor or fetal distress may occur. So continuous CTG monitoring can be done.
And the role of continuous CTG monitoring is ideally to identify hypoxia. And we know that it is not a very reliable test because it's got a better negative predictive value than a positive predictive value, isn't it? So among the CTG patterns, if you have a normal CTG pattern and the presence of accelerations, they are really, really good indicators of a low probability of fetal complication. However, we cannot expect accelerations for all women in labor, and this, if present, is a good feature. However, when there is rise in baseline or decelerations, these tend to be useful predictors for acidemia. And we find that there is a higher proportion of these abnormalities occurring in the obese mothers, in those who are nulliparous, those who are older, and those that have diabetes. So I think we have to be prepared for CTG abnormalities more in these women, and we have to interpret it in a very methodical manner. Stillbirth is a particular risk. Professor Sumati, can I bring you in on this? Because with the load of patients and wealth of experience you have, I'm sure many a times we have all faced this situation. What is your top recommendation to the audience for avoiding stillbirth, madam, for a gestational diabetes? Madam, your mic is on mute, madam. Sumati, madam, your mic is on mute. Yes, madam. Yes, madam, your mic is now unmuted. I'm not able to hear, madam. Sumati, madam, I'm not able to hear you. Are we able to hear, madam?
No.
Madam, maybe your volume is turned down. Do you want to check, madam? Sorry, madam, we are not able to hear you. Is Professor Vanita here? I'm not able to see, madam.
Vanita ma'am is there.
Vanita.
Mic is on mute.
Unmute your mic, madam.
Madam?
Yes?
Yes, madam.
Yes, please continue.
The question was on
stillbirth prevention for a mother with gestational diabetes.
Yes, madam. Good glycemic control is the key cornerstone for avoiding stillbirth, and we have to go for diagnosed diabetic vasculopathy if it is there, or macrosomia. Both are both.
Please continue, madam.
Especially if the baby is macrosomic, or if the baby has features of IUGR, then I'll be more worried. And I'll increase the intrapartum, antepartum surveillance. I'll go for close monitoring. And intrapartum, you're talking about intrapartum stillbirth, madam.
Yes, madam. Yes, also intrapartum. Yes.
Intrapartum.
So you mentioned antenatally, you will look at good control, growth disorders in the baby, and the need for therapy. These become indicators to be more proactive with the management. Intrapartum?
Intrapartum, mainly the glycemic control during labor. Around 120, we have to keep the blood sugar under control.
So meticulous
and
management
CTG,
of blood sugar is very
and the progress.
Around
CTG,
the time.
monitoring and the progress of labor, we have to keep on assessing.
Very good. So with the diabetes, the other thing to remember is if we have given them steroids because of prematurity, then there is a higher risk of the mother developing hyperglycemia because of the steroids in the first 4 to 6 days. As a result of which, if a delivery happens within 4 days of steroids, then there is more chance of neonatal hypoglycemia for the baby, especially if the mother has not been monitored adequately. I will move on to postnatal care now so that we can get the eminent input from Dr. Santosh Kumar. Madam, I will wind up in another 5 to 7 minutes. I hope that is okay.
Yes, ma'am. Yes, ma'am.
So the newborn care is extremely important in this particular condition because not only have we learned about how to screen, how to monitor in pregnancy and bring a safe timing to delivery, but we still have to watch the baby even in a well-controlled gestational diabetes. So we look at this scenario wherein we have delivered a 3.8 kilogram baby at 38 weeks after GDM being identified 4 weeks ago. I would like Dr. Santosh Kumar's input about when should the early feeding be started? And can we give artificial feeds? As you know, we are now in an era of cesareans. I'm not promoting that, but given that on an average, it will take 1 hour to finish a cesarean and come out of theater and have the patient ready. Quite often giving artificial feed tends to be a good option. What do you think, sir?
Good evening, ma'am. So with regard to the initiation of feeds, there is some physiology that we should understand. So basically, there is hyperinsulinism in the fetus, and there is a cutoff of sugar from the mother. So the fetal glycogen starts getting utilized, and by around 30 minutes to 1 hour, the baby's blood sugar will fall to the lowest levels. So your feed should be within 30 minutes. So that is the basis behind the initiation of feeds within the first 30 at a max between as early as possible or within 30 minutes. So that is the basis of first initiating feeds early. And with regards to breastfeeding and artificial feeds, it's always better to breastfeed the baby. Even if there is a difficulty in breastfeeding, you can express the breast milk and feed the baby. And breastfeeding has shown that giving breastfeeds reduces the long-term complications that can arise in these babies with born to mothers with gestational diabetes. Like they are more prone for diabetes themselves in the later life, and they are more prone for metabolic syndrome. So breastfeeding actually reduces the risk of these infants developing these long-term complications. So from previous studies and literature, it has been shown that every month extra that a mother breastfeeds reduces the incidence of this metabolic syndrome that an infant develops who is born to a gestational diabetic mother by 4%. So it is ideal that you breastfeed the baby. If there is a difficulty, you can always express the milk and feed the baby.
Thank you, sir. So it is universally recommended that it should be breast milk and early feeding, isn't it? And also we looked at the blood glucose levels that were required for control. And though we mentioned that we can have values up to 140, values of less than 126 tend to be better values to give a good outcome for the baby. And we also, sorry, please carry on, sir.
And adding to that, the better glycemic control, the better the chances that the child doesn't develop an hypoglycemia or complications related to GDM, because all this is related to fetal hyperinsulinism, and when there is a persistent hyperglycemia in the mother, the chances that the child develops hyperinsulinism and its complications are far more than when the mother is having a good control.
So, sir, I would also like to share with you that in the last, even before I left the NHS 11 years ago, it was almost standard practice in most of the units which looked after diabetes to request mothers to do antenatal breast milk expression. And it was a choice given to the mothers. And this is a practice that I see we are continuing to do in the National Health Service currently as well. Have you got any experience in this, sir? And what is your view about it?
We have at Saveetha Medical College, we do this. We have got multiple. Actually, we have got an RCT running on in our unit right now with respect to colostrum. Actually, it's not colostrum expression from the milk mother, and actually swabbing the child. So that swabbing the child's mouth, it's called as colostrum swabbing, or giving the initial colostrum, which again significantly reduces the chances of the child developing hypoglycemia. And even the other, apart from providing a nutritional support, this colostrum is being a biological, it's actually a biological weapon against infections and other problems that that an unit can face. So we are doing it in our unit right now. So this is a
the clear message here is we are going to avoid artificial feed. We are going to try early feeding, and even things like a skin-to-skin contact of the mother and the baby is a very helpful way to promote the establishment of the lactation. And the small amounts that the colostrum come itself is a large, very good medication to help hypoglycemia prevention. Isn't that right, sir?
Yeah, perfect.
So I'll go on to one more scenario, which sir has kindly shared with us, so that we can highlight the point about hypoglycemia better. This is a macrosomia suspected baby and a birth weight of 4.6, delivered in good condition, and breastfeeding was established in the delivery room. But when the bedside glucose was done 30 minutes after delivery, it was 15 milligram per deciliter. Sir, is this a value you would be concerned about? Because we use different values for the adults and we use a different value antenatally and postnatally. What is your cutoff for hypoglycemia?
Neonatal hypoglycemia is basically defined as there are no actual definitions to define neonatal hypoglycemia as such, and it is just an operational guideline that is followed. So several studies have shown that once the blood sugar level falls below 40 or 47, around 40 to 47, the baby develops these neuroglycopenic symptoms. So based on this, the American Academy of Pediatric, the ACOG themselves have defined neonatal hypoglycemia as any serum or a plasma blood sugar less than 40 milligram of deciliter, and a capillary blood glucose which is 45. So that is what is the definition. And generally the capillary blood glucose level is not reliable because the capillary blood sugar is unreliable at lower levels. It is basically designed to identify hyperglycemia. So this CBG monitor is basically designed to detect diabetes in adults, and when we use them in newborns at a lower value, it is likely to give far values which are unreliable. So that is the reason why CBG is not a reliable marker of hypoglycemia, and you should do a serum sample. And a serum sample of less than 40 is considered as hypoglycemia in newborns. And between 25 to 40, you can feed the baby and reassess within 30 minutes. But once the baby is, that is called as asymptomatic hypoglycemia. But once the value is less than 25, even if the baby is asymptomatic, it needs to be treated, because at 25 milligram of deciliter, the chances that the child develops neuroglycopenia and the subsequent complications are far higher. So if for this baby having a blood sugar of 15 milligram per deciliter, the baby needs to be started on a dextrose bolus, followed by maintaining the baby on a glucose infusion, so that he doesn't go in for brain damage.
So the take-home message for all babies of gestational diabetes, even when they look well, we should do an early blood sugar test. Isn't that right?
Yeah, yes.
So we have looked at this mother who is now persisting to have low values, and you have given us the care protocol. And apart from neonatal hypoglycemia, do you want to list the problems that a neonate of a diabetic mother will commonly run into?
Yeah. So as discussed previously, the basis of all this is fetal hyperinsulinism. Once a baby has a fetal hyperinsulinism, this hyperinsulinism causes macrosomia. Macrosomia leads to a state of chronic hypoxia. Because of this chronic hypoxia, the baby starts producing erythropoietin, and this erythropoietin causes increase in the bone marrow production of cell lines. So this erythropoietin leads to polycythemia. So polycythemia and hyperviscosity are two major complications of infant of diabetic mother. So this polycythemia and hyperinsulinism, this hyperviscosity in turn can lead to excessive hemolysis and cause hyperbilirubinemia. And these are the three major metabolic complications, that is polycythemia, hyperviscosity, and neonatal jaundice. So with respect to hyperviscosity, the chances that the child developing thrombosis because of hyperviscosity also increases, and the child can have renal vein thrombosis, cortical vein thrombosis, and these are the other complications that a child can have. Apart from that, there are other metabolic which develop primarily because of the parathormone response to the baby. Calcium is not adequate, and there's excessive calcitonin also, and this leads to hypercalcemia and hypomagnesemia. Generally this presents on the second day of life and not immediately after birth, like hypoglycemia presents. And these are the metabolic complications. Apart from that, an infant of diabetic mother can have this congenital problems. Generally it is associated more with pre-gestational diabetes rather than gestational diabetes, because the congenital malformations occur during the period of when the baby is affected during the period of embryogenesis. So we have already discussed in detail the complications: CNS, CVS. You can have skeletal. CNS, basically caudal regression is the most specific. Apart from that, you can have neurative defects, cardiac septal defects, and asymmetrical septal hypertrophy is a very common problem, but mostly underdiagnosed. So in our unit, we have many cases of asymmetrical septal hypertrophy who have been treated with beta blockers of propranolol. So these are some of the complications.
Thank you. So you've highlighted about the electrolyte imbalances, about the polycythemia and the jaundice. Do you want to very briefly, because we are run out of time, just tell about, apart from diabetes, are there other situations where you can see a baby having hypoglycemia?
Any baby like an IUGR baby, any baby who is a preterm baby, is like, or any late preterm babies who have got feeding issues can develop the hypoglycemia. So preterm babies, late preterm babies, IUGR babies, or SGA babies, or any baby with any large for gestational age baby as such can have hypoglycemia.
So not only diabetes, but even a macrosomic baby without diabetes, we have to monitor for blood sugar values postnatal. Professor Vanitha, can I move over to you to give the concluding remarks about the postpartum care for the mother? Because we have now delivered her. What will be the follow-up of gestational diabetes that is required for her?
Once the GDM has delivered, the insulin resistance comes down, and hence there will not be any need for insulin if she's a pure case of GDM. So again, at 6 weeks to 12 weeks, we are supposed to do a fasting OGTT. And we take the two values and we diagnose either as normal. Am I audible, madam?
Yes, you are audible, madam. Please continue.
At 6 weeks, we do the OGTT again, and we look for the fasting and postprandial value, 2-hour postprandial value. And we diagnose either as normal or impaired GTT or frank diabetes if it's more than 125 and 200 postprandial value. So, and we have to keep them on annual follow-up every year, as they are more 50% patients may become a type 2 GDM later.
Madam, also I wanted to highlight to all our audience, the breastfeeding benefit was highlighted by our neonatologist for the baby, but also breastfeeding is known to reduce the risk of diabetes for the mother also. And the mothers who maintain a healthy diet are also known to have a better outcome for the child's metabolic profile also. So
yes,
the treatment
also,
is very important.
should we talk about prophylactic antibiotics also for the diabetic mother? Here we usually give antibiotics if she's a GDM.
Why, madam?
To prevent infections. They are more prone for infections. So we
generally, the role of antibiotics and the potential for antibiotic-induced change in microbiota for the mother is something that is currently on evaluation. So role of antibiotics, from my understanding, is for those where there is a proven infection. What about the long-term impact of the mother and the baby? Over to Professor Sumiti and Professor Rajalakshmi. Can we start with Professor Sumiti? I'm sorry, madam, I could not hear you before. Professor Sumiti? Professor Rajalakshmi?
Yes, ma'am.
Yes, ma'am.
Long-term impact of mother, they are more prone for developing type 2 diabetes and cardiovascular diseases and chronic kidney diseases. And baby, as Sir Santosh has said, they are more prone to develop obesity, overweight, insulin resistance in future, and neurocognitive developmental delays.
So our focus will be for bringing on a transgenerational impact by improving the care of gestational diabetes. So we'll just come to the concluding remarks. We would like to take as much as possible preventive steps, and maintaining a healthy lifestyle of eating and physical activity is something we should promote in all pregnant women. And there are ways to enhance compliance by providing better service as a team. And now a lot of apps are available, text message based services, motivational interviews, online consultations, all improve for the compliance of the patients. And these are things that we can consider. I would like to hand the mic back to all the panelists to give each of their brief concluding remarks. Can I start with Professor Sumiti, please? Professor Rajalakshmi?
Yes, ma'am. So we are supposed to screen for GDM by around from the first antenatal visit and from and at around 24 to 28 weeks with 75 gram OGCT, and the value should be FBS should be around less than 95, and 1 hour PPBS should be less than 140, and 2 hour PPBS should be less than 120. So
that is when that is the target values when we have diagnosed diabetes and to keep it in good control.
Yes. So suppose if the values are abnormal, we can start her on medical nutritional therapy, and after 2 weeks, we have to repeat FBS and 2 hour PPBS. So our target value should be FBS should be less than 95 and PPBS should be less than 120. If it's more than 95 and 120, we can start them on OHS or insulin depending upon the blood sugar values. So, and intrapartum and intrapartum antenatal care should be given properly. And intrapartum, we have to monitor blood sugar levels during intrapartum because stillbirth chances are more in GDM patients.
Professor Vanitha, would you like to give your concluding remarks, madam? Madam, your mic is on mute.
Postnatally, we have to concentrate more on the obesity, weight control, diet, exercise, and explain to her that she might become a future GDM 50% recurrence rate, and hence we have to start nutrition therapy or something. We have to lifestyle modification mainly. We have to advise for these patients now.
Professor Vanitha, I think you brought home a very important message where, especially the obesity, it is the responsibility of the obstetricians to explain weight loss And achieving an ideal BMI is really important for their own personal health. And I think that's where all the lifestyle changes come in. And it is a FIGO recommendation also that we discuss this with the patients. Dr. Malati, would you like to give your remarks, please? Dr. Malati, your mic is on mute. Dr. Malati? Can I move to our neonatologist? I think Dr. Malathis may not be hearing us. Dr. Santosh?
Yes, ma'am. So the central thing to everything with respect to newborn management would be the good obstetric care that is being given. The chances that a child developing complication, neonate developing complication can be significantly reduced if the glycemic control of the mother is taken care in the antenatal period. So that is a thing that I would like to say. So if the mother is having a good glycemic control during the antenatal period, the chances of the baby developing these complications like hypoglycemia or polycythemia are significantly reduced, and the chances of the baby coming out well is also higher.
So you, together as obstetricians and neonatologists, we can bring on the breast impact by being methodical with our care. Thank you to everybody. And I apologize for some of the connectivity issues where I could not listen to Professor Sumati and also to Dr. Malati at the end. Thank you. And over to you, Hepzibah, madam.
Thank you, madam.
Stop sharing, Dr. Lakshmi. We want to see you all. Yeah, thank you. It was a wonderful panel. We learned a lot of things. You have simplified so many things. It was very interesting to listen, and we learned a lot of things also. How to do a methodic screening and how to monitor the patient both antenatally, intrapartum and postpartum. Thank you so much for the wonderful panel, the moderator and the panelists. Shanti, Dr. Shanti.
It was a wonderful, interesting and a practical case-based discussion, madam. I thank the moderator, Dr. Lakshmi ma'am, and the eminent panelists for sharing their day-to-day experiences to improve the care of the GDM, starting from, as madam mentioned, from the screening and providing screening for GDM, providing care, antepartum, intrapartum care. And as you mentioned, the management of GDM doesn't stop with the delivery of the baby, but it is a continuum which has to be carried out in the postnatal period for the baby and for the mother to avoid long-term complications. Thank you so much, madam.
Thank you, ma'am. Now, coming to the end of the session, I would like to invite Dr. Kohila, madam, to deliver vote of thanks.
Yeah. Good afternoon, Ananda. On behalf of Fetal Medicine Unit, Department of OBG, Saveetha Medical College, I am here to deliver the vote of thanks. My heartfelt gratitude to thank our founder and chancellor, Dr. N.M. Veerayan sir, and our vibrant director, Sumatch University, Dr. Deepak Nallasamy, and our beloved Dean, Dr. Damodaran, who gave their full support to conduct this webinar. Thank you, sir. It gives me immense pleasure to thank our chief guest, Professor Dr. Anjalakshi ma'am, who is the President TNFOG, for always being enthusiastic in conducting scientific sessions and workshops. Thank you, ma'am. And I want to extend my thanks to the organizing secretary, Professor Dr. N. Hepzibah Kirbamani ma'am, for always being the motivator for us. It's my gratitude to thank the speakers, Dr. Preeti Jami, Director, Chennai Women's Clinic and Scan Center, and Dr. Sudarshan, Fetal Medicine Specialist, Mediscan Systems, for their crisp and wonderful lectures. I want to thank especially the moderator of panel discussion, Dr. Lakshmi Shanmugasundaram, who is working as a consultant from Frimley Park Hospital, Surrey, UK, who gave her precious time for this webinar. It was a wonderful discussion, ma'am. Thank you. And I want to thank the panelists, Professor Dr. Vanitha ma'am, Kilpack Medical College, Professor C. Sumati ma'am, Deputy Superintendent, KGH, for their active participation. I want to extend my thanks to the panelists, Dr. Malati Prasad, who is a fetal medicine specialist, Trichy, and also my beloved teacher. And also I want to thank our faculty, Dr. Santosh Kumar, Neonatologist, Saveetha Medical College, and my colleague, Professor Dr. M. Rajalakshmi. I extend my gratitude to the chairpersons, Professor Dr. Parimala, Professor Dr. Niti Sharma, and Professor Dr. Shanti. I also want to acknowledge the academic partner, Scans, for this wonderful webinar. Last but not the least, I want to thank all the delegates for this webinar. Thank you all once again.
Thank you.
Thank you,
Thank you,
ma'am.
Lakshmi. Thank you, Shanti, Archana, Gokila. Thank you, Mr. Balaji. Thank you. See you at some time, Lakshmi.
Thank you so much, madam.
Thank you, madam. Thank you.